All right, well, I just want to welcome everybody back from break. And we have a really exciting resident paper session. And I'm going to introduce our first speaker, and it's Dr. Alex Marks, and he's going to be speaking about revision rates and trends in diagnosis and management of combined ACL and MCL injuries.
Get to start off their presentations as well. All right, so as Dr. Laroque said, I'll be talking about the following topic. No relevant disclosures. And as we all know, combined ACL and MCL injuries represent the most common variant of multi-ligamentous knee injuries, with the current treatment algorithm traditionally being for grade 1 injuries, MCLs are managed non-operatively, while operative management of the MCL is reserved for higher grade injuries. However, trends and outcomes based on the management of MCL injuries at the time of ACL reconstruction have not been extensively studied. And so the objectives of our project was to compare rates of revision between patients with isolated ACL reconstruction to those who had concomitant MCL injuries managed either operatively or non-operatively at time of index ACL reconstruction. We hypothesized that patients with concomitant injuries, particularly those who had surgery for their MCLs, would have worse outcomes. And so to do so, we used the ProDiver database and queried all patients who underwent ACL reconstruction between 2016 to 2020 with 2-year minimum follow-up. And patients were further divided by injury pattern into subcohorts, with isolated ACL injury being one cohort, and then concomitant ACL and MCL injury being the second cohort. And the concomitant injury cohort was divided further into non-operative management of the MCL, MCL repair, or MCL reconstruction. And the patients were excluded if they had a primary diagnosis of knee dislocation or subluxation, PCL, LCL, or PLC injury, concomitant HTO, DFO, or prior ligamentous reconstruction or repair. Baseline demographics of age, sex, BMI, tobacco use, and Charleston Comorbidity Index were queried, as well as rates of complications and need for revision ACL reconstruction. We used t-test, ANOVA, and chi-square tests as appropriate to identify or to compare our identified patient cohorts and analyze trends. And then multivariate logistic regression was used to assess the association between demographics and isolated ACL injury versus ACL injury with concomitant MCL injury, isolated ACL injury versus ACL injury with concomitant non-surgically treated MCL injury, operatively treated MCL injuries versus non-operatively treated MCL injuries, and then lastly, MCL repair versus MCL reconstruction. And so moving on to results, a total of 58,152 ACL reconstruction patients were identified with the database. Of those, 47,000 patients had isolated ACL injuries and 10,000 had ACL injuries with concomitant MCL injury. The cohorts were similar in baseline demographics. And amongst the 10,846 patients with concomitant MCL injuries, 93% were treated non-operatively, 4.7% were treated with repair, and 2.7% were treated with MCL reconstruction at the time of index ACL reconstruction. And despite the majority of MCL injuries being managed non-operatively, the annual proportion of patients being surgically managed for their MCL injury increased by 70% over the study period, from 5.5% in 2016 to just over 9% in 2020. Moving on to complications and revisions, patients with concomitant MCL injuries had higher rates of ACL revision surgery at 1, 2, and 5 years after index ACL reconstruction, with 4.7% of patients with initial concomitant MCL injury undergoing revision at 5 years compared to 3.2% of patients with isolated ACL injuries. Amongst patients with concomitant MCL injuries, patients who'd undergone MCL reconstruction had higher rates of ACL revision compared to non-operatively managed patients and MCL repair patients at 1, 2, and 5 years after index ACL reconstruction, with over 10% of patients who underwent both ACL and MCL reconstruction at 5 years requiring subsequent revision surgery, revision ACL reconstruction, And then regarding meniscal injury, concomitant MCL injuries had higher rates of meniscus tears as well as subsequent meniscectomy or meniscus repair. And the knees that underwent MCL reconstruction had higher rates of meniscal pathology and subsequent meniscectomy or repair. However, when comparing ACL reconstruction and non-operatively treated MCL injury with ACL reconstruction, the operatively treated MCL injuries to operatively treated MCL injuries, there was no difference in subsequent meniscal surgery. Stiffness was also a large factor with ACL-injured knees and concomitant MCL injuries, with the concomitant injuries having higher rates of postoperative stiffness and subsequent MUA and lysis of adhesions. And then operatively treated MCL injuries were more likely to undergo MUA and lysis of adhesions than non-operatively treated MCL injuries. In our multivariate logistic regression analysis, patients with concomitant MCL injuries had an increased likelihood of requiring revision ACL surgery with an odds ratio of 1.5. Tobacco use, younger age, and higher CCI were also negative independent risk factors for revision ACL reconstruction. And then similar measures of association were found when comparing isolated ACL injured patients to concomitant MCL injured patients that were treated non-operatively for their MCL, with non-surgically treated MCL injuries having an increased likelihood of requiring ACL revision surgery. Amongst patients with concomitant MCL injuries, patients with MCL surgery had higher odds of revision ACL reconstruction with a ratio of 1.39, with age, BMI greater than 30, and tobacco use remaining as significant risk factors for revision. And then lastly, among patients who had their MCL injuries managed surgically at time of index ACL reconstruction, MCL repair patients had significantly lower odds of ACL revision surgery compared to the MCL reconstruction patients. So in conclusion, despite an increase in operatively managed concomitant MCL injuries, the majority of concomitant MCL injuries are still managed non-operatively at time of ACL reconstruction. And patients with concomitant MCL injuries, particularly those managed operatively at time of ACL reconstruction, are at increased risk of requiring revision ACL reconstruction compared to those with isolated ACL injuries. Thank you.
Great, thank you. And then I'll introduce our next speaker is Dr. Angel Zhao, and she's going to be speaking about lower extremity injury rates on turf versus natural grass surfaces and analysis of professional football athletes.
Hi, I'm Angel. I'm one of the R2s, and I obviously have no disclosures. So background, artificial turf has been used in the NFL since about 1966. The big driver of this decision was their multi-use capabilities and then the ease of upkeep, specifically with different weather conditions. Over time, the turf field constructs have been a little different, but they've pretty much been standardized in the NFL so that by 2005, all NFL stadiums had either natural grass or this modern infield surface known as field turf. Recently, there's been a lot of concern about the different biomechanics of this field turf compared to natural grass. There have been some studies that have shown that cleats on synthetic turf have different release mechanics and load absorption. And the concern is these release mechanics lead to more loading stress across the knee and ankle. Whereas in these studies, grass has been shown to release the cleat prior to reaching these injury loads, which overall decreases shear force and torque on the foot. Clinically, though, there's been a lot of conflicting data. So there have been studies that show that synthetic turf is associated with higher rates of ACL injury and eversion ankle sprain, as well as higher rates of knee injury in NCAA college turf games. There have been other studies that similarly, or that conversely show no significant difference in injury rates in collegiate women's soccer, as well as high school football. And then the big thing is there's a lot of conflict of interest in this topic. There are 3 studies that, of course, show there's an increased injury on natural grass, but these 3 studies have all been sponsored by the turf industry. So the purpose of this is to quantify and categorize the rates of lower extremity injuries in NFL players on turf versus natural grass. And we focused on lower extremity injuries given these biomechanical studies that propose this mechanism for increased injury. Secondarily, we wanted to characterize the degree of time missed due to these injuries to give us kind of a proxy of the severity, and then similarly, the proportion of these injuries that ultimately went on to surgery. So we pulled data from the 2021 and 2022 NFL seasons, looking at scouring through news reports of players that were injured and how much time they missed. For every injury recorded, we found the field type, the player position, age, weather that day, history of previous injury in that player, injury type, and then whether or not they went on to surgery. The outcomes we were able to pull, so we looked at injury incidence on grass versus turf. We looked at subsequent weeks missed because of this injury, and then the incidence of injury requiring subsequent surgery on grass versus turf. Using surgery as our outcome, we did a multivariable analysis to look at risk of injury requiring surgery, and these are the different factors that we pulled that we were able to control for. So in terms of results, in total there were 16 turf stadiums, 14 grass stadiums. Total injuries across those 2 years, about 718, and it's about even between those 2 years. We also broke that down by player position, and we grouped player position based on the kinds of activities that those players are expected to perform. So notably, most injured players were the secondaries, the cornerback or safety, and then secondarily would be the running back, fullback, tight end position. So this is the breakdown of kind of all of the injury incidents over years, and then we used weeks missed as kind of a proxy to look at the distribution of severity of injury. I think it's a lot of numbers. So most importantly, if you look at the combined data, on grass, the incidence was about 1.22 injuries per game compared to turf, which is 1.42, meaning that for every game played, there was on average 1.22 lower extremity injuries on grass, 1.42 on turf. And then if you go all the way to the right, the incidence of injuries requiring subsequent surgery on grass was 0.18 compared to turf, which was 0.31. These are small numbers, but in the context of kind of the NFL, that's still an increase. And then if you look at the distribution across the kind of our proxy for severity, it looks pretty much equally distributed for both turf and grass. So the main focus we wanted to look at was surgery. So the most common surgeries that were performed after injury included Achilles tendon repair, ACL reconstruction, and then ankle or syndesmotic ORIF. On our bivariate model, we found that history of prior injury and field type were the only two factors that affected risk for requiring surgery. And then in the multivariate model, the odds ratio of surgery on turf, of an injury sustained on turf compared to grass was 1.6, and that was statistically significant. Other factors like weather, age, position, week of the injury occurring, meaning that if it occurred later in the season versus earlier, and then history of previous injury, none of those were statistically significant. So in conclusion, our big takeaways from the study is that there's a higher incidence of lower extremity injuries on turf compared to natural grass. The odds of injury leading to surgery were significantly higher on turf versus grass, and in particular, we found ACL injuries, Achilles injuries, and ankle injuries. Limitations, the big limitation of the study is that we had to use public records to collect the data, so there could be an underestimate of incidence, especially because not every small injury was reported, and because we were using public data of games, we weren't able to capture data from practice sessions or preseason, for example, that could also affect player decisions to stay or to not play subsequent games. We had an inability to account for game day surface conditions, so we knew the weather, but there are NFL measures that they kind of use to look at the ground condition based on the weather, which we weren't able to account for. And then obviously patient personal factors or team factors would also affect your decision to pursue surgery or to sit out of a game. So next steps, I think this study does a good job of looking at trends of injury on these two different surfaces and could help inform decisions on player safety, and then also potentially inform developments of new field turf materials to address this biomechanical issue, and then potential footwear during games. These are my references. Thank you.
Great, thank you. And then our next speaker is Dr. Ramesh Ganta, and he's going to be speaking about adoption of reverse total shoulder arthroplasty for surgical treatment of proximal humerus fractures differs by patient's race.
Good morning, everyone. My name is Ramesh, and I'm also one of the second-year residents here. Today, I'll be presenting our study examining the racial differences in utilization of reverse total shoulder arthroplasty for the treatment of proximal humerus fractures. This study was performed with Drs. Lachandani and Shapiro as senior authors, and we have no relevant disclosures. Proximal humerus fractures are a common problem, representing the third most common fracture in patients over the age of 65. Given the aging population of the US, the number of these fractures managed over the coming years is expected to rise significantly. In general, minimally displaced fractures can often be treated non-operatively, but for displaced proximal humerus fractures, options are open reduction and internal fixation, and some of you in the crowd will recognize that one of our attendings has a particular affinity for this treatment option, hemiarthroplasty, and reverse total shoulder arthroplasty, with the reverse total shoulder arthroplasty largely replacing hemiarthroplasty recently. In recent years, there's been increasing data highlighting the benefits of performing reverse shoulders in elderly patients with proximal humerus fractures, perhaps highlighted by the Delphi trial from 2020, demonstrating increased patient-reported outcome measures, as well as increased range of motion at 2-year follow-up. There's also been a well-documented trend in all of orthopedics of racial disparities in treatments received for various conditions, with subspecialties like hip, knee, and shoulder arthroplasty all demonstrating racial biases in who receives certain treatment modalities and their outcomes. Therefore, we sought to compare racial differences in the surgical management of proximal humerus fractures, with our null hypothesis being there would be no difference in operative intervention received by race. To do this, we looked at a national surgical quality database known as NSQIP, identified all surgically treated proximal humerus fractures from 2006 to 2020 using ICD-9 and 10 codes, collected the treatment received, ORIF versus reverse shoulder versus hemi, using CPT codes linked to appropriate ICD codes. Also using these ICD codes, we excluded open fractures, fracture dislocations, and fractures of the shaft or distal humerus. We also obtained all demographic and clinical variables available in NSQIP, performed a univariable analysis, and factors significant at a 0.1 level were included in a multivariable regression analysis to predict operative intervention. So for our results, we identified 7,500 patients who'd underwent operative treatment of proximal humerus fractures. 87% had ORIF, 26% had reverse shoulders, and 7% had hemis. With respect to racial breakdown, 27% of white patients with proximal humerus fractures received reverse shoulders, compared to 21% of black patients, 15% of Asian patients, and 15% of Native American and Alaskan patients. And these were statistically significant differences. With regards to demographics, age, sex, BMI, and ASA class were all significantly associated with the type of intervention in a univariable models and were thus included in the multivariable analysis. Looking at the year-by-year breakdown, utilization of reverse shoulders increased over time with an odds ratio of 1.2 per year, which was significantly different, and hemiarthroplasty also decreased over the same amount of time. For our multivariable analysis, incorporating all the previously mentioned factors, we found that non-white patients had significantly lower odds of receiving reverse shoulders compared to ORIF with an odds ratio of 0.75, as well as male patients also having lower odds of receiving reverse shoulders. In addition, we found those over 65, those with a higher ASA classification, and those with an overweight or obese BMI had higher rates of undergoing reverse shoulders. Reflecting on our findings, there's overall a need to analyze and understand racial disparities in treatment of all orthopedic pathologies, and proximal humerus fractures are not an exception. This is critical to ensure equitable access and care to emerging orthopedic technologies. In our national database study, we found non-white patients underwent reverse shoulders at lower proportional rates compared to white patients, even when controlling for confounding variables such as age, BMI, and ASA classification. In considering the reasons for this, there are several possible explanations. One could come down to surgeon implant availability in different geographic distributions, with it being possible that areas where minorities tend to live have a lower density of shoulder arthroplasty trained surgeons. While there are other factors that have been suggested in other subspecialties, such as surgeon implicit biases, cultural beliefs, and medical mistrust, and all of these could play a role in the differential utilization of treatments. There are certainly limitations to our study. The first is that this is a national database study. NSQIP does tend to have high quality data input from over 600 institutions, but it's possible that institutional sampling is not representative of the US as a whole, as NSQIP is more representative of academic institutions. Also, NSQIP does not have access to original imaging or clinical documentation, so we're forced to rely on documented ICD codes, which are subject to error. And finally, NSQIP only gives us access to operatively treated fractures, so we're not able to directly assess rates of non-operative management of these fractures, which certainly has implications in the overall treatment paradigm for proximal humerus fractures. So in conclusion, as utilization of reverse shoulders increases for the treatment of proximal humerus fractures, our study found there's potentially racial disparities in the utilization of this treatment modality, and understanding the root causes for this disparity are crucial in order to maintaining equitable access to care. Here are our references, and thank you very much.
Great, thank you. And then I'm going to introduce our last speaker for the first part of this session, and it's Dr. Fabian Su, and he's going to be speaking about, does MR arthrography improve evaluation of patients with posterior instability, an analysis from the Moon Shoulder Instability Group.
All right, good morning, everyone. These are disclosures, none of which are relevant to this talk. So posterior shoulder instability is uncommon and it accounts for approximately 10% of all shoulder instability events. However, these injuries can be devastating as only 35% of young athletes return to sport at the pre-injury level and 60% return to sport at some level at long-term follow-up. The diagnosis of posterior shoulder instability is often difficult given that the presentation is vague and that physical exam maneuvers like the Kim and jerk test have limited sensitivity. Advanced imaging, such as MRI, can aid in a diagnostic evaluation of patients with posterior shoulder instability, and multiple prior studies have shown that MRA to be superior to MRI in the diagnosis of labral lesions. However, these studies were all limited by combining patients with anterior shoulder instability, slap tears, with patients with posterior shoulder instability. So, in the literature, it is unclear what the benefit of MR arthrography over conventional MRI is. Furthermore, arthrography is a invasive procedure to the patient and requires additional cost and time. Therefore, the purpose of our study was to compare the accuracy of MR arthrography and conventional MRI in detecting labral, chondral, and osseous lesions in patients with posterior shoulder instability. We hypothesized that the MRA would be superior to MRI. So we work with the Moon Shoulder Instability Group to address this question. Moon Shoulder Instability is a prospective multi-center study that started enrollment in 2012. The study is based out of the University of Iowa and includes 10 other sites, including UCSF and Vanderbilt University. So a total of 310 patients with posterior shoulder instability were enrolled. 13 did not have an MRI or had an incomplete MRI, and an additional 5 patients had an acute traumatic effusion, which were excluded. Thus, our final cohort consisted of 89 patients with conventional MRIs and 230 patients with MR arthrograms. A fellowship-trained musculoskeletal radiologist with over 10-year experience and an orthopedic surgeon evaluated all images. They were all blinded to all clinical information except that patients with posterior shoulder instability was their diagnosis. Images were evaluated for the presence, location, and size of labral, chondral, and osseous lesions, and all MR images were at least 1.5 Tesla field strength. Fisher's or chi-square tests were used to compare the sensitivities and specificities of MRI and MR arthrogram using arthroscopy as the gold standard. So there were no differences between patients who received an MRI and MR arthrogram, except that patients who had an MR arthrogram were a bit younger. On imaging, we found that labral tear was present in 95% of patients. These tears tended to extend from the 7 o'clock to the 11 o'clock position, and the tear size on MR was about 155 degrees. These tears, when compared to arthroscopy, were a bit bigger by about 45 degrees. Looking at the sensitivity, both MRI and MR arthrograms had excellent sensitivities in the 95-96%, although their specificity was much lower. There was no difference between these two imaging techniques. Turning our attention to glenoid bone loss, 34 patients had glenoid bone loss on imaging compared to 4.4% of patients on arthroscopy. The mean bone loss was 11.8%, and the mean vector of bone loss was 823. MR arthrography did have a higher sensitivity than MRI, though this was not statistically significant, and there was no difference in the specificity. Moving on to the humeral side, we see that on imaging, we found 12.8% of patients had a reverse Hill-Sachs lesion compared to 11.4% on arthroscopy. The mean depth was 2.4 and the mean width was 10.7. For identifying reverse Hill-Sachs lesions, both MRI and MRA had excellent sensitivity and specificity with no difference between the imaging techniques. And lastly, looking at chondral lesions, 9.9% of patients had a glenoid cartilage lesion compared to 18.6% identified on arthroscopy. Most of the glenoid cartilage lesions occurred in the posterior and posterior inferior regions of the glenoid. And 13% of patients also had a humeral-sided cartilage lesion on imaging compared to 15.4% on arthroscopy. Both MRI and MR arthrography had very poor sensitivities in identifying glenoid and humeral cartilage lesions, and there was no difference between these imaging techniques. So it's important to consider the results of the study in the context of its limitations. First, it was a single reader. It was a highly skilled, high-volume musculoskeletal radiologist. So these results may not be necessarily extrapolated to a community practice. Furthermore, the MR protocols differed among institutions in terms of field strength, pixel size, slice thickness, and sequence type. And lastly, the duration between imaging and surgery varied between the modalities. So the results of the findings suggest that the addition of an arthrogram does not improve diagnostic evaluation of labral, osseous, or chondral lesions in patients with posterior shoulder instability. And it is also important to highlight that an arthrogram is an invasive, time-consuming, and costly procedure. To put things into perspective, using 2024 Medicare data, the arthrogram increases healthcare costs by 283%. So I think as healthcare costs continue to increase, these findings would suggest that the addition of an arthrogram does not justify its use in patients with posterior shoulder instability, given that it does not add any diagnostic benefit. Thank you.
Great, thanks a lot. And Fabian, actually, just while we're tailing on your talk, I just had a question. First of all, were you surprised that there was no significant difference in terms of with and without the arthrogram detecting posterior labrum tears, and just how do you think that extrapolates into other areas of the labrum in terms of recommending arthrogram versus no arthrogram?
So I think that one thing that I noticed is that we often look for like a linear white line in the labrum to determine whether or not it's torn. From a radiologist's perspective, I discussed with them, you have to look at the morphology of the glenoid labrum. So if it's lost its triangular shape, if it looks bulbous, those are all other imaging signs that the labrum is torn. And as we start to read more and more of these MRIs, it becomes quite apparent that you can just kind of tell without an arthrogram.
Okay, thank you. Yes, and Dr. Louie and Dr. Wright, do you have any specific questions for the presenters?
Yes, I do. Yes. So for Dr. Zhao, an interesting paper. Obviously, I commend you for all the hard work combing through sports articles. It's kind of my passion as well. But to your knowledge, obviously, the information you shared with us today would basically be gold for the NFL Players Association to convert all these fields to grass, obviously. To your knowledge, is there a similar study being done and shared information between the team physicians of these NFL teams? And if so, why aren't they sharing that to the public?
So it's incredibly hard to get access to the NFL database. They're pretty private about that. There was an early study of kind of athletic trainers within the NFL who noted something similarly, but I believe that data was between like the early 2000s, 2010. So it was before they all standardized to field turf. And so a lot of that data is pretty variable. And I think that people are kind of hesitant to make that big switch. And I think that a lot of the times like I mentioned, there's like a benefit to having that turf. So a lot of work has also been put towards making that turf itself better, aside from just switching.
So to follow up on that, so first of all, I think all the studies just show the power, great job everybody, and show the power of large database and the ability to really find significant findings. But yes, this has been seen in the league with increased ACL and external rotation syndesmosis injuries. And I argue, so we took care of the Rams until we sent them back to y'all in California a few years ago. And I would try and convince the players to use shorter cleats on field turf, but they're so afraid of losing traction and getting burned or beat. And they wear the same length, a lot of them wear the same length cleats on turf as grass, and the turf doesn't give exactly like you showed. And so something has to give, so it's their ankle or their knee. You had a huge jump and I forget the years, 2021, 21, 22, on the field turf injuries. I mean, it was a big jump in injuries. Do you think that was just an aberration, or did something change?
Yeah, we were actually talking about how many years we wanted to include in the paper, just because with COVID and kind of the way that the NFL changed along with COVID, there might have been some change in kind of game dynamics and ability for players to practice, things like that. So I think going forward, it would be good to kind of go back potentially to even 2005 to kind of capture more and standardize for that.
Great. Well, I think in interest of time, we can move on to the next session. Okay, so for our next session, in lieu of Dr. Ryan Halverson, we have Dr. Drew Lansdowne, one of our faculty members, who's going to be discussing language analysis predicts needs for surgery prior to clinical exam or imaging, and analysis of nearly 3,000 pre-visit patient questionnaires at a sports medicine clinic.
All right, thank you, Dr. Laroque, and thank you all for being here and for having us as part of the program. So Ryan Halverson is one of our residents, and he's at a family event. He's sad to miss it, but I'll be presenting in his honor. So our disclosures are updated. None are relevant to this presentation. So to start, the impetus for this project is that with specialized physicians in a large group, I think matching patients with physician-specific expertise can be challenging. We often rely on a call center, patients to self-identify, and there may be mismatch between the physician's expertise and what the patient is exactly looking for. I think an ideal triage system would be one where you can match the patient with the physician or the provider who is most likely to be able to provide care that is needed in the appropriate time frame. I think it's also interesting to look back, and something that we've all probably heard is that a careful history will lead to the diagnosis 80% of the time. This is supported by data from the 70s, but we're all told in training that you have to listen to the patient, that they will tell you most of the time what the diagnosis is. Like if we hear they have a pop, they're playing sports, like it's probably an ACL tear, like I can't move my shoulder, it's probably a frozen shoulder. But this information just directly from the patient can tell us the problem that we're gonna treat. So in our sports medicine clinic, we will often have the patient fill out a pre-visit questionnaire. We've moved to getting this online prior to their visit before they've met us at all. For this proposal, we sought to use an AI language model to decide if surgery was likely, more info was needed, or surgery was unlikely. And the thought being that maybe we can use this information to better match the patient with the skill set that they need. So the purpose is to use large language models to predict the need for surgery for new sports medicine clinic patients using only their pre-visit questionnaire data. So this is not incorporating any available imaging, any available extra information, just the words of the patient themselves. The hypothesis is that patients requiring surgery can be identified with reasonable accuracy from these questionnaires. So to perform this, we looked retrospectively across the available data that we have from May 2020 to May 2023. And then we categorize patients as having surgery within 30 days, 90 days, 1 year, or at any time. And then all of the model features are just derived from this patient inputted questionnaire. This is our questionnaire that we use, and this is unstructured. This is meant to be information that we find useful before we meet the patient. So what side are we seeing for? What part of your body is injured? Was there an injury? And then free text for the patient to fill in. Our model evaluation, so we used natural language processing, large language models, and used 5 different models just with various features of processing ability to try to see, is one of these able to predict the best. We used typical training testing methods, taking an 80% for the training set and then 20% for testing, and then evaluated with the area under the ROC curve, along with post hoc text analysis to see if key terms really predicted what would happen. So in our population, about half of the patients had surgery at any time. A small percentage, about 10%, had surgery within 30 days, and then increasing across the board. The model performance, so these are those 5 different large language models, and then our best performance was with a random forest model. And this had 92% accuracy in predicting surgical need within 30 days with an area under the curve of 0.67. The other models also performed well, but kind of outperformed by that random forest model. What we found in our post hoc text analysis, we had increased odds of surgery if the patient specified their pain duration in days rather than larger units, so kind of reflecting an acute injury. If they had tried at least one prior treatment modality prior to their visit, if they described NSAIDs, injections, PT, narcotics, or prior surgery. And then if their pre-visit questionnaire mentioned a pop or a tear, that was associated with a higher chance of having surgical treatment. So through this study, we've shown that in nearly 3,000 new patients visiting a sports medicine clinic, an AI-based large language model was able to identify patients requiring operative intervention with reasonable accuracy using only the data that they provide us prior to their clinic visit. I think this suggests that this language analysis of patient free text data could be employed in combination with machine learning models to triage new patients presenting to clinic. So if we know that I have available OR time next week, and this patient has an acute injury that needs surgery, they should be matched with me. If a partner has the OR time, or if they need an ultrasound-guided injection, other procedures, we can better demand match with the need that the patient has. So some limitations, these PAQ surveys were not optimized for this analysis. This is just using the data we have that's available. The model accuracy may improve as we ask more targeted or specific questions. And so in conclusion, I think prioritizing the evaluation of patients at high risk for intervention could decrease the time to surgery for those who need it, while freeing up other resources and personnel for patients in need of conservative treatment modalities. Thank you.
Okay, and so for the next session, in lieu of Dr. Matt Churches, it's going to be one of our faculty members, Dr. Mir Marmer, presenting regarding validation of use of previously collected Apple iPhone health data to determine current performance level.
Thank you. And last night, when I realized I was giving this talk, I found this picture to remind me that I still love these people, and good luck to Matt and his wife with labor and everything. All right, so disclosure is this study was done in UCSF Human Performance Center with a grant we got. Background is that patients with injuries and fractures, and specifically, we often base our treatments on what we perceive as their pre-injury function. So their low demand, high demand, low function, high function, and obviously this is very subjective. So we thought to take advantage of this new age where everybody, I assume everybody here in the room is wearing some sort of wearable, and if you're not wearing a wearable, you're wearing a smartphone, which is a activity measurement wearable. So everybody has them. So the question is can we use the data that's just routinely collected on your smartphone to make valid predictions of how healthy you are, or what's your activity level? So the purpose of this study was to assess the correlation between activity on the app that metrics that monitors your activity on your phone, and to correlate and to see if it correlates to actual laboratory performance lab metrics. We hypothesized that this is the case. Our methods was to take 11 healthy volunteers. We chose 11 because that's what the grant paid for. There was no fancy sample size calculation. We already demanded that these people are already using an app to record their activity. We used only Apple iPhones because it's very popular in this area of the country and this part of the country. And then we wanted to standardize as much as possible. Like I said, the UCSF Human Performance Center did the testing. And then we just use a simple correlation just to see if there's anything correlates between what's on your phone and the metrics on the lab. The metrics that were on the phone are routinely collected on an iPhone are step count, exercise minutes, flight of stairs, climb, standing hours, sleeping hours, respiratory rate, and heart rate variability. The Human Performance Centers record, this is the basic human performance test. It's VO2 max, grip strength, sit to stand, 6-minute walk, vertical jump, and timed up and go. So our results was we found some high correlation. For example, grip strength was correlated to your median heart rate variability in the last week. I also didn't mention, but we checked for every metric, the weekly average, the monthly average, the yearly average. So we did figure out what's the most important time period to measure it. Relative VO2 max, for example, was correlated to minimum heart rate variability, and you see the absolute max was correlated to maximum heart rate variability. So I don't know what to make of that, but those are the correlations. Jumping height was highly correlated to the maximum respiratory rate in the past month, and these are healthy volunteers, so it may be just they're exercising more, so they're breathing faster. I don't think anybody has COPD now in our resident volunteers and some of them. Sit to stand, you can see some lower correlation, time up and go, heart rate maximum correlated to that. So this graph is not intended to be read, but it's intended to be looked at and qualitatively appreciate. The high intensity red is a positive correlation, high intensity blue is the negative correlation, like a perfect negative correlation, close to 1. And you can see there's a bunch of these. On the bottom, there's all the metrics on your iPhone in a weekly, monthly, and yearly average. And on the left side, you see all of the Human Performance Center metrics, and you can see there's a lot of dots. So this is just a pilot study, proof of concept. So should we pursue this to a bigger study? And it seemed there are some correlation. There is a signal, as we like to call it, here that there's some high correlation between the two. So we think that routinely collected smartphone data may contain accurate information about the person's pre-injury physiological health and activity level. Successful validation of this approach may offer clinicians a novel tool for objective preoperative activity evaluation, leading to more personalized surgical decision-making and post-operative rehabilitation regimens and goal setting. For the geriatric population, which I'm more interested in, that happens to use smartphones, objective quantification of frailties may be possible, which is a big deal. Our limitations, obviously, we used only iPhones. It was only 10 patients. It's very difficult to generalize. The Samsung measure the same metrics, the same accuracy. We don't know. But it does give us, it motivates us to continue and research this field. So in conclusion, initial results suggest that the bring your own device model, which just bring whatever device you have, may offer and will use it to measure your health, may offer an accurate insights regarding patient physiological capacity prior to injury, and future studies involving larger populations or prospective designs is justified. Thank you.
Okay, and next I want to introduce Dr. Kat Woolley to speak with us about evaluation of spin bias in randomized controlled trials and clinical trials of mesenchymal stem cells for the treatment of knee osteoarthritis.
All right, thanks for having me. I'm Kat, I'm one of the third-year residents. All right, and I have no relevant disclosures. So you may have heard that MSCs can treat or even cure osteoarthritis. MSCs, or mesenchymal stromal cells, are multipotent cells which can differentiate into various types of mesodermal cells, including osteocytes and chondrocytes. This has led to a hype surrounding stem cell research, with many claims that are not necessarily backed by science. The media also retains a highly optimistic coverage and timeline for stem cell therapies, leading to unrealistic expectations. And many MSC trials are at risk of bias, with limited numbers of patients, inconsistent randomization and blinding, lack of controls, are often funded by the company itself, as in the case with Regenx here, and other confounding factors, including spin bias. The AAOS has included other orthobiologics, such as PRP, in their treatment guidelines for knee arthritis, but has not commented on MSCs. Spin bias has also already been investigated in other orthobiologics. So given the hype and lack of literature surrounding MSCs, we decided to focus on MSCs instead of other orthobiologics with this study. What is spin bias? Spin bias is the intentional or unintentional misrepresentation or misinterpretation of results to appear more favorable than the findings justify. So running for your life or running can be good for you. All right. In this study, we aim to characterize the presence of spin bias in clinical trials of MSCs for knee arthritis. The secondary intent was to analyze any study characteristics and its association with spin. We hypothesize that there will be spin in about 50% of trials and will be associated with lower impact journals and those with financial disclosures. In order to do this, we first performed PubMed and M-based searches for MSCs for the treatment of primary knee arthritis. All studies were uploaded to a data sheet and screened by 2 coders for inclusion criteria. The data was collected from the article in the paper. The type and level of spin was analyzed using methodology from a prior study by Boutron et al., who first described spin in randomized controlled trials. They broke it down into 3 different types of spin. Type 1 was a focus on statistically significant results. Type 2 was interpreting statistically non-significant results of primary outcomes as showing treatment equivalence or comparable effectiveness. And then type 3 was claiming or emphasizing the beneficial effect of the treatment despite statistically non-significant results. They further broke this down into high spin, moderate spin, and low spin, with high spin having no uncertainty of framing, no recommendations for future trials, no acknowledgement of non-significant primary outcomes, and recommending its clinical use. Moderate spin had some uncertainty of framing, did recommend future trials, no acknowledgement of non-significant outcomes, and then did not recommend its use. And then low spin had uncertainty of framing, recommended future trials, acknowledged non-significant outcomes, and then did not recommend its clinical use. And framing just refers to the context and language used to convey the results. No uncertainty of framing meant that the authors conveyed the message that the results led to their conclusion without acknowledging any other possibilities or flaws. After an initial search, 55 manuscripts were ultimately included. Spin was found in 81.8% of papers, with 14.5 having high, 25.5 moderate, and 40% low. Only 18.2 of the manuscripts did not have spin. We found that type 1, emphasizing statistically significant results, was the most common, followed by type 3, claiming treatment benefits despite non-significant results, and then finally type 2, the least common, interpreting non-significant primary results as treatment effectiveness. Adipose-derived MSCs were associated with a higher frequency and level of spin compared to other sources. Spin was found less frequently in the methods section compared to others, and it had the highest frequency in the results section, though this was not significant. There was no difference in spin between orthopedic journals and non-orthopedic journals, and there was no association between spin and impact factor. Papers with financial disclosures exhibited spin in 82.5% of cases, while those without, 33.3%, and this was significant. Here's an example of type 1 spin, which is focusing on statistically significant results. Here they note that 2 patients in their treatment group of rejoin did not respond to the treatment, but conveniently, if you removed them, the results became significant. And then type 2, this is interpreting non-significant primary results as treatment equivalence or effectiveness. And here they claim that the VAS in both groups reduced over time, but was considerably higher in their treatment group. This again was not statistically significant. They also claim that MSC implantation is an easy approach for pain relief and repair of damaged cartilage compared to other approaches. And in this study, they didn't conduct any imaging or biopsies to assess the cartilage. And then in type 3, this is claiming treatment benefits despite non-significant results. This manuscript was a clinical trial of 3 patients with no statistical analysis, and here they claim that MSC transplantation seems beneficial for the joint. So SPIN has not been widely described in orthopedic randomized controlled trials, but shows similar rates to other surgical subspecialties. Prior studies that have looked at spin bias in orthopedics have found a lower rate than ours, but they only reported on the abstracts. Our study found the highest rates of spin in the results section, indicating that only reporting on the abstract may underrepresent the true levels of spin. Additionally, prior studies focused on top journals with a more narrow scope, and we looked at all studies. And then additionally, we demonstrate an association between financial ties and spin bias. Prior studies have indicated that randomized controlled trials with financial ties are more likely to recommend the experimental drug as the treatment choice. Some limitations include the small number of included trials. We don't know the effect of this limitation, but again, we reported a higher prevalence of spin than broader studies. And future studies should include larger studies with strict spin screening guidelines. So in conclusion, how can we screen for and avoid spin bias? We can read the entire manuscript, paying special attention to the primary outcomes, the statistics, and the claims made in the conclusion. We should also check for financial disclosures. And when writing papers, we should be sure to explain our results without pushing a conclusion, and we should include uncertainty of framing and be sure to recommend future trials. And how does this change things? I know for me, it's convenient to read an abstract, but I think this pushes me to read the full paper for sure. And we should have more skepticism when papers do not use uncertainty of framing and are industry funded. And then finally, journals should publish negative or null results. We do think that there is a bias amongst research to have significant results. And if journals have a special column for negative or null results, which are arguably just important as positive results, this may kind of lower the pressure to induce bias and have positive results. And I'd like to say thank you to Drs. Feely, Master, and Milan. And here are my references.
Great. Thank you so much, Dr. Woolley. I think we'll start with taking any questions from our visiting professors.
Drew, that's really interesting. Do your pre-visit questionnaires end up in, or y'all, what's your EMR?
We use Epic.
Yeah. And so one of the problems we're having, and I was telling Ben, we're actually looking to get rid of all of our pre-visit questionnaires because every clinic, every specialty has a different one at Vanderbilt, and it's not ending up in Epic, and the patients feel like they're getting the same questions, multiple clinics, So how are you using these visit questions beyond predicting how quickly to get them in?
Yeah, so we actually use them clinically, and they're sent to the patient electronically ahead of time, and through MyChart they can complete them, and then they are pulled directly into our note. And so we have that, what happened, why are you here, what do you like to do, what are your goals, what are your questions? And the data that we're collecting, it's really for clinical use only. And then we just thought maybe we can take a look at this and see if this could be useful before we even meet them. But that's like most of our HPI is built off of just the data that they're inputting.
Yeah, that's interesting because part of the reason we're getting rid of them is because we find that you just go in the room and sit down and ask the exact same questions of the patient, and the patient's like, But if you're using it as a way to then auto build the note, that's interesting.
Yeah, thanks.
Dr. Woolley, fabulous paper. That really was enlightening. To your knowledge, has spin bias been applied to other journals specifically? Because I think what you did really outlined and highlighted how obscure some of the real data is, and the fact that journals are skewed to getting a significant result. And I think there's merit in doing a study with no significant results as well. So do you think going forward there'll be an emphasis on spin bias in addition to telling us what level of evidence it is?
Yeah, yes, thank you. Spin bias it's kind of a newer thing, and a lot more publications are coming out on it. I think orthopedics is just starting to be investigated, but it has been previously described in other surgical subspecialties and other non-surgical subspecialties in their associated journals. So I think as we bring more light to it, hopefully there are kind of changes in the way we present our papers and our findings to help limit that.
Great. And I just have one more question actually for Dr. Lansdowne. So it does seem like for sports that this language analysis seems to work really well, right? Like pop or swelling, something like that. But I'm just wondering, have you thought about, say, extrapolating this language analysis to maybe other subspecialties like spine or arthroplasty, where those patients aren't having necessarily an acute injury, and trying to figure out, which one of those patients might be more likely to need surgery within 3 to 6 months?
Yes, definitely. I think it's a great point. And we started with sports just to start there, but I think we can expand to other clinical services. And even, in the arthroplasty direction, it may just be matching, like, are you really ready for a joint replacement? Should you be speaking to the surgeon now, or an APP? Like, are you in that pre-contemplative phase? But I think there's other directions as well. And then we're starting to look at likelihood of undergoing advanced imaging, shortly after the visit. Or having another procedure. So I think a great direction would be if we say, hey, there's a 90% chance that you need an MRI, and look, the slot's held this afternoon, we'll see you, examine you, and then if that's true, like, you're downstairs and getting a scan right after. But I think we could really expedite that decision-making, or the next steps, rather than saying, hey, all your information suggests this is the direction we're going, but we'll meet you first, 2 weeks later we'll schedule it, then we'll see you again. But we could have this much more streamlined by using this type of information.
Right, and for example, in sports, we do ask, hey, what conservative treatment have you tried, right? So if it's somebody that, say with an arthroplasty patient, they've already tried a brace, an injection, physical therapy, they might be more likely. Dr. Wistrak, you have a question?
Yeah, thank you. All of those talks are great. I actually have a couple of questions and a comment. Drew, the contact center is coming.
Yes.
So, just for those of you that don't know, UCSF is switching to one point of contact. And so all of us have to kind of change how we've been triaging patients to a centralized unit. And there's a lot of algorithms going into this process. It's about a 8 to 9 month process to get your practice into the contact center. So this would actually be a really great opportunity. And have you talked to anyone at the contact center about use of AI in this process and what might work for sports?
Yeah, thanks. And I think that's a great point. We have not spoken to anybody, but I could see that being the direction, because I think as we move towards this larger model, the people who are triaging are even further removed from our clinical practice, and they may not know what our expertise is or what patients are best for which provider. So having these tools, I think, would be extremely beneficial to make that process a lot more seamless.
Yeah, I would encourage you to try to get on the ground floor of that, because it's really been a struggle at the Cancer Center. And then, Kat, I loved your presentation. And did you find, I've got to find the words, but did you find that with the high spin bias, yes, there were more conflicts? Were those studies paid for by the company? Because when I was a resident, we did a study just looking at the placebo arm of this prospective randomized zoledronic acid trial. So we were only looking at the placebo patients. It was just a natural history study, but every round of the manuscript had to get cleared by people from the pharmaceutical company. And so they actually had their hand in every part of the process, including writing the manuscript, which didn't even talk about zoledronic acid. So I can't even imagine what's happening when it is talking about their product.
Yeah, that's another really good question. And we're actually working on this with one of our reviewer comments at breaking down the financial disclosures, whether they're industry sponsored or not. And I can't remember the exact number, but I want to say about 60% were industry sponsored, and then the others were more grants. I think we need to look a little more closely and really make sure we've divided them between the two. But we're continuing to look at the results and the further breakdown of those. But I would say the majority were sponsored by the company itself.
Great, thank you. And I think we have time for one more question, and then we will take about a 10-minute break. Yes?
I'm going to ask myself a question. So, no, question for Kat. So, isn't the job of the reviewers Isn't the job of the reviewers to weed out the spin out of papers? So if you looked at the quality of papers that they were submitting to, so I would assume that a high quality paper would weed out this spin. And the other question is, how objective is the spin determination process? Or in other words, was there spin in your paper?
Yeah, I think another really good question. Wait, I forgot the first part.
The first quality of journals.
Yes.
Yeah.
No, I would have thought that as well, but we didn't find an association between impact factor and not. And we also looked further at orthopedics versus not, because the orthopedic journals had some pretty top tier journals, like Journal of Sports Medicine, knee, arthroscopy, and then there were other littler journals that was like regenerative molecule medicine, some very low impact journal people hadn't heard of, and there was no association, interestingly. And then the second question was, what was your second question?
How objective is determining
yes.
the spin?
Yeah, our paper certainly could have had spin bias. I have tried to be so cognizant of this while writing it because that would be just very ironic, but it's very difficult, like I said, to convey a conclusion of a paper without pushing that conclusion. And so I think we tried to really rely on the statistics and say, this is what the statistics show, this is the conclusion we're drawing, but here's a reason, why it couldn't have worked. And then in terms of the objectivity, we used the prior methodology from another study that inherently is a little subjective as you read. What is if they have their how is their framing, that could be different between the two reviewers. So we had two independent reviewers and then a third reviewer that kind of spot checked things. And if there were any discrepancies, we made sure we got to a unified decision. But that is a very good point. It's maybe we need a language model to really help us objectify that.
Sure. So there's actually no break. This discussion is just a little longer than the last discussion. Do we have time for one more question, Rosie? Okay. I think Dr. Birch had a question.
Drew, I just want to ask you first. So in your questionnaires, do you ask the patient if they want to have surgery? Because my favorite is when the patient comes in and I say, yes. Hey, you need surgery. And they're like, surgery? I never want surgery. And so do you ask them whether they want surgery?
We don't, but that's also where this is just purely to get us some information to get that HPI started. And that could be totally incorporated and I think would be great. And that's so often, we see the exact same thing. I'd never have surgery for this. It's like, well, great.
The sign on the door says surgeon. So,
yeah. But little tweaks like that could totally make this even better. But this is even, unstructured, not even intended for this purpose, and we're still seeing a benefit of using the information.
Right, and then the opposite to that is, well, then what do you do with all the people who still want to come and see you, but, don't want to have surgery?
Totally, and you could potentially see, do you still want to talk to that person, that expertise, or would you rather steer clear of it completely? And I think there are still beneficial discussions with patients who are not going to have surgery, and that's an important part that we play. But I think it's just that matching of expectations and desire from the patient with what we can offer, and I think when we do that better, I think people will be happier.
Great. I think we'll break there to stay on time, and Dr. Ma will do the next introduction. Thank you.
Great job, guys. Yeah, Shane, they just want to come see you, right? They don't need once the big spine surgery. Just want to say hi to you, Shane. That's perfectly okay. Want to talk about back pain, right? So, well, thank you, everybody. I think the room is a little bit colder. We actually acknowledge it. I think the team is working on bringing the temperature up a little bit. I saw Dr. Woostrak have her kind of shawl on and actually have the hot coffee, so we are adjusting the temperatures, just, we are aware of this. We can make it more comfortable in the second half. So it's my great honor to introduce the 68th Leroy Abbott, visiting professor, Dr. Rick Wright. Rick's a friend, mentor of mine, over the years. So I will share a little bit about his background. Rick actually did his Bachelor of Science and got a medical degree from University of Missouri, Columbia. did his residency in Vanderbilt, and went to Minnesota. Did his sports medicine fellowship. It has changed a few names, over the years. I went to St. Louis to become faculty, and I actually got to know Rick since 2002 when I was a fellow. And he kind of really mentored me and actually a couple of friends of mine over the years in terms of doing clinical research. He had a illustrious career in WashU St. Louis. He was head of sports medicine. Became executive vice chair of the department. Most of us have seen great letters of recommendation through Rick Wright over the years. Have great candidates come through as residents with us at UCSF. And he also was the director of the Orthopaedic Clinical Research Center over there. He was recruited back to Vanderbilt in 2019, became the chief of the and chair of the orthopedic department, and became a Dan Spangler professor and chair of the Department of Orthopedic Surgery. He was also, recognized for his leadership skill and became chief medical officer and also senior vice president of clinical affairs 2023 recently. Besides the impact he has in his in a hospital, he's actually also the president of the AOA and also a current board member of the ABOS. And actually, he's actually some secret, but he does have some leadership role within AOSSM coming up also. And besides his leadership activity, he's also a great clinical researcher. He was a founding member of MOON, which is a multi-center orthopedic outcomes network, which I think some of you are familiar with, and mostly look at ACL injury, now expands to the shoulder and other areas also. He also is the brain behind MARS, which is a multi-center ACL revision study cohort, which is a study that's going to show some of the results up to us about what the findings are. Really change how we take care of patients in terms of ACL injury, and also with revision surgeries over there. So without further ado, I want to kind of introduce Rick Wright to come speak to us about revision ACL reconstruction issues and outcomes. Thank you. Yeah.
So thanks, Ben. I'll just say one thing before I forget about it. I ran a decentralized local orthopedic access, our contact point at WashU. And then I was access medical director for the enterprise, which is completely centralized. And I think at the end of the day, if you do it right, centralized can offer some benefits, but it's scary when it's coming at you. And I'd be happy to talk to you all about whoever in the department's kind of tasked with that. There's some key things that can make centralized access actually better than decentralized. So anyway, and a little bit of a kindred spirit with Dr. Abbott. I don't know if y'all know much about, some of you probably know his history, but he also was at WashU and ran the Shrine and was a professor at WashU and for I think 7 years, and then left to come home to UCSF, and I was at WashU for 25 years and then left to go back to where I had trained. So we have a little bit of a similar background. So we're going to spend, for some of you, way too much time talking about revision ACL reconstructions, but hopefully there's some other lessons in here. Conflicts, we have NIH funding for MARS. My personal conflicts really don't have anything to do with any of the implants or anything we do in MARS, but I've worked with responsive arthroscopy, which we're trying to make generic implants to decrease costs across medicine, and then stock options with Hylex and Consultant. So ACL reconstruction, as we talked about some this morning, is the treatment of choice for ACL deficient patients. If you look at industry data, they always like to say 200, but if you really look hard at industry data, there may be as many as 500,000 ACL reconstructions a year. And the primary reconstructions work pretty well, but they do fail at a real level that does impact taking care of these patients. So the results of ACL reconstruction, good for stability, at least in the short term, but you can have some things go wrong, including loose motion, extensor dysfunction, arthritis, and graft failure. Today, in this revision talk, we're going to focus on graft failure. So if you go back to when we were putting MARS together, back then people said the ACL graft rupture rate was around 1% to 8%. We looked at MOON, and it was 3%, and also 3% in the contralateral knee at 2 years. But these are a mixed bag of patients of all ages. systematic review that Kurt Spindler had done looking at hamstring versus BTB, around a 4% rate. And then we did a minimum 5-year follow-up of ipsilateral versus contralateral that we published and found 6%, about 6% in ipsilateral, but double the risk in the opposite knee of tearing once you've had your ACL reconstructed. But then if you start to look hard at young active individuals, you find out that this failure rate actually can be pretty high. So Morgan looked at minimum 15-year follow-up of reconstructions in patients under the age of 18. They were all autografts, so all the graft that you want to see in a teenager with good follow-up, and found that 31% were re-injured. 11%, 27 or 11% tore their ACL graft, and 13% tore the opposite knee, and another 6% tore both the ACL graft and the contralateral normal knee. So that's really, that's a high number. That's worrisome. If you really dig down into the results, you'll find a 17% ACL graft rupture at 15 years, contralateral rupture at 19%, with a contralateral 25% in males versus 12% in females. So males were really high risk of contralateral injuries. Wiggins did a meta-analysis of 19 studies. The ACL re-injury rate was age and activity stratified, and overall a 7% ipsilateral, 8%. But if you look at that under 25-year-old group, which is the real risk group, 21% combined ipsilateral and contralateral. And if they return to sport, 23%. So 1 in 4 were tearing either the graft or the opposite knee. So this is really a little bit higher failure rate than we had imagined. And the problem is that for those of us that do sports, the patient tears a graft and they look at it like an oil change, because they got an ACL graft, they went back to sports, they did pretty well, went back to playing soccer, basketball, volleyball, whatever, they're doing great. They tear the graft, they go, well, let's just do it again. But the problem is that the results aren't nearly as good in the revision setting as the primary setting. And so they want to get back to what they were doing, and they don't understand the bad results. So we have to do a good job of understanding what those results are and what predicts those results, so that we can tell the patient what to expect, so we can be realistic about them returning to sport and activity. So why do ACL grafts fail? If you go all the way back to the 80s, and we were first starting to do modern ACL reconstructions with decent grafts, a lot of it was technical. But you can also have biological graft incorporation problems with soft tissue grafts, so any graft, but allografts and soft tissue probably the highest. And then traumatic re-injury, you're going, I always tell the patient, you tore the one God gave you. There's no reason you can't tear the one I give you. We're pretty, surgeons can be pretty egotistical, but I don't think I'm putting in a better graft than they were born with typically. Those early studies showed that most of the time it was technical. We were putting the tunnels in the wrong place. So all the early studies showed a 50 to 80% technical failure cause. You'll see in our data showing here that this may be trending towards we're doing a better job and they're more traumatic. From an outcome standpoint, what outcomes can a patient expect after a revision ACL, and what ones actually matter? And yes, I know some of you don't think so, but we do play football at Vanderbilt. It's tough in the SEC. We're at the bottom of the pack every year, but we do show up on Sunday, and people love coming to Nashville for the games, because they can actually, Georgia and Alabama fans can actually get tickets in Nashville, where they can't get tickets in their own stadium. So revision ACL reconstruction, there's really not a study out there that shows equal results to primary. This was the consensus of everyone that signed up for Mars. It was the strongest predictor for KOOS score in our initial Moon cohort. It was the strongest predictor for worse outcome in Kurt Spindler's pre-Moon 5-year follow-up study. But there's really no level, when we started Mars, no level 1 or 2 evidence really out there to guide treatment. There's a bunch of level 4 case series and no series that showed a better result with a revision set of patients than primary. So I decided to, while we were putting this together, to do a mixed model meta-analysis of what was out there. So we found 21 studies with minimum 2-year follow-up following ACL reconstruction. The whole 21 studies combined was 1,000 patients, which I think then will show you some of the strength that we've been able to bring to the topic with MARS. There were 4 level 1 or 2, 1 level 3, and 16 level 4. So a bunch of retrospective case series. Objective failure defined as re-revision or a high KT or a pivot shift was about 13%, which compared to all the primary studies out there was definitely higher. And then the patient-reported outcomes were globally worse than any primary series. So we had started MOON. We had 10 surgeons that had started MOON, and we had collected about 500 ACLs, and we had looked at 2-year follow-up, and what we found is that 10% of them were revisions, and revision was the biggest #1 predictor of a worse outcome. But we also knew that it had taken us a couple years to collect 47 revisions, so we couldn't collect them fast enough to get enough to do true multivariable regression analysis. Because for each variable you include, and let's remember that the revision ACL has a lot more variables involved because of the previous surgery and all that. So you need at least 10 to 15 ACL or patients for each variable that you include. And so we just weren't going to get there with 10 surgeons. So that's when we decided that we needed to expand this into a true national multi-center approach. So a single MOON wouldn't do it. We needed to plan it. And we decided that we would probably continue the same study design that we had for MOON, which was a prospective longitudinal cohort. And everyone said, why don't you want to do an RCT? Well, these are some of the reasons. RCT, you can really look at one variable. You can randomize graft, or maybe 2 variables. Prospective longitudinal cohort, you just enroll everyone, and then you follow them and see what happens. Once you say, hey, I'm going to randomize you, the patient goes, I don't think so. So look at every randomized trial in JBJS, and it's usually under 50% participation of the people that were offered it. The randomized is nice. The statistics are simple, but for about $1 million grant, you can look at one variable. Longitudinal cohort, we knew from MOON and MARS now that you tell the patient, it won't change your care. All we're going to do is follow you and see how you do. Patients participate. We had 98% participation, and $1 million, and you can look at 50 or 75 variables, which we've been able to do. And just to understand this a little bit better, the most famous prospective longitudinal cohort in medicine is the Framingham study. So they enrolled 5,000 patients that were free of cardiovascular disease to see what happened to them. And so they used multivariable analysis to identify independent predictors of cardiovascular disease. So you can't randomize family history. You probably shouldn't randomize smoking. Can't really randomize high cholesterol, blood pressure, and you don't want to randomize exercise, although most patients would randomize into the non-group. But what you do is you follow these people and see which of those things that you can't randomize then end up predicting outcome. So that's the Framingham study. I think we all know about it, and that's how you think about a longitudinal cohort. We're going to follow these patients and see what causes them to have a bad outcome. So we took it to the AOSSM board. The research committee bought into it. More than 100 surgeons participated in 4 training design sessions. We currently have 83 IRB approved surgeons at 52 sites. The great thing about it's very generalizable. It's a 50-50 mix of academic and private practice. Actually more private practice. It's about 55-45 truly. So a lot of people are able to participate in this and contribute, and it's just really been good for the society, and we've learned a lot. And this has been one of the great sites, written some of the papers, high participation here. It's been UCSF have been great partners. So here's a map of our sites, obviously skewed a little bit like the academic centers and population, not much in that western part of the country, nobody in Wyoming, in Mars. So our first study, we enrolled 1,234 revision ACLs. So remember that. We had 2-year follow-up on 21 studies. Total was 1,000 patients. So this eclipsed the entire medical literature of revision ACL follow-up. So we did the epidemiology, and these were what ended up being our 3 specific aims and exploratory aim on the NIH grant we got to continue to follow them. It's 58% males, median age was 26, with a range of 12 to 63. It's really sad when you're 12 years old and undergoing a ACL revision. So, really important to take good care of these patients. The revision number, 87%, it was their first one, but that means there were more than 150 in the cohort that were on their second or higher revision, some as many as 5 that were on their 5th revision. That's really, you got to figure out what's going wrong because something's not right. Time from last ACL, remember we talked about technical issues, but in this cohort, 55% were more than 2 years out from their primary or previous ACL reconstruction. So that makes you start to think that maybe they get back to activity and then they get hurt and it's traumatic re-injury. 3/4 were hurt playing a sport. Most common sports were those that involve both men and women. Basketball, football's up there, but basketball and soccer were the 2 most common sports where both genders can participate. Cause of failure, and you could say more than one, that's why it adds up. So you could say it was a combination of technical and biologic or whatever. But this is really one of the very first studies and groups and cohorts to show that maybe traumatic re-injury has become more common. Now, the kicker on that, so here's the Venn diagram, and you can see the overlap when people said there was more than one cause. The kicker on that traumatic re-injury is that 334 of the patients were the surgeon's own failure. And so when asked why did it tear, you go, no, I put the tunnels in the right spot. This was a traumatic re-injury. But we did have on 2 occasions where the surgeon said, no, I screwed it up. I put the tunnels in a bad place. But this may skew it a little bit towards traumatic re-injury. What's the cause of the failure? Far and away, people think it's the femoral tunnel, but the tibial tunnel may be a problem area that we just don't recognize. Not much varus or valgus malalignment, fixation really not that common, and posterolateral, posteromedial laxity not that common. Most of the patients were autografts, so most of them previously had an autograft that failed, 2/3. So everyone kept saying it at meetings while we were getting it up and running in the first couple of years, Rick, what graft should I be using? I said, wait a minute, we'll get you there. We got to figure it out because we all wanted to know because there were people that strongly loved using allografts, people like to use autografts, and people just wanted to know what graft should we be using. So that was the first thing that we wanted to ask and answer. So we had 92% phone follow-up, we had 82% questionnaire and another 10% that also we were able to at least track down by phone and ask them if their graft had failed. Did multivariate analysis, 88 variables, and it was looking at auto versus allograft and soft tissue versus BTB in both of those groups. So remember we said we couldn't do a randomized trial, but the data, I couldn't have made the data layer out any better. We were basically, and the reason it doesn't add up to 100 is you've got a small number that were both auto and allo where they'd add an allo to an auto. But if you look at it, half and half auto and allo, and in each group about half and half BTB and soft tissue. With soft tissue allograft including a soft tissue fixation on one side. So an Achilles allograft would be soft tissue. Soft tissue obviously for autograft is almost, there were no, like I said, there's no quads in here. You know, now it would have a ton of quads, but hamstring. So about the only rule we had was that if you used an allograft, it had to be MTF, and that was because that way we could know how it was processed and how it was sterilized and how it was handled and that we could track it. And so MTF handles their grafts 4 different ways. They test them for a bioburden, they run cultures and all that, and if everything looks clean, they just process it aseptically, no radiation. If it looks just like so contaminated that it's bad, they can throw the whole specimen away, the whole body away, the whole cadaver. Or if it's light bioburden, they may give a light amount of irradiation to the whole body, but not directly to the grafts that you're going to use. And then at customer request, you can get terminal sterilization of the graft, which is probably the bad actor when we have thought that radiation may contribute to allograft failure. So looking at the autograft versus allograft, in general, the allograft group was a little less active and a little bit older. Median age 28 versus 24, and Mark's activity level 10 versus 12. We don't know a minimal clinically important difference on the marks. It's not been studied, but it's probably around 2 points. It runs from 0 to 16. So the allografts were just a little bit less active and a little less active at 2 years. So we got, like I said, the follow-up, track subsequent surgeries, followed the op reports. Looking at the IKDC, which is one of the sports subjective proms, IKDC was improved with autograft with an odds ratio of 1.33 and a p-value of 0.04. Coos subscales, sports and quality of life are probably the most sensitive for ligaments, and they were both improved with autograft with an odds ratio of 1.33. ADLs and Coos symptoms, no difference between the two groups, but that's basically, can you do ADLs? Probably not going to be that impacted by allograft or autograft. Here was the real money data that people wanted to know. The re-rupture rate, we had at 2 years, a 3.3% re-rupture rate with 12 autografts and 24 allografts. So the autograft use was 2.78 times less likely to re-rupture than the allograft. We could not demonstrate a difference in soft tissue versus BTB in either auto or allo. So autograft better than allograft, 2.78 times less likely to rupture. Everyone said, yeah, Rick, but see, you don't understand. I use fresh frozen allografts and my grafts are good and see, mine are fine. Well, actually, then we were able to look at that. And more of the allografts that failed were actually fresh frozen, non-irradiated. And so we could not show that there was that much of a protective effect. And only a couple surgeons used terminal irradiation. And this whole body irradiation probably is not a significant enough dose to matter. And so we couldn't show that the reason the allografts were failing was because of irradiation. If you use a fresh frozen allograft, you were protected. And so I can't say that that's that an allograft can hold up if you do that. So then we looked at it at 6 years. I actually thought, my hypothesis was that at 6 years, we would stop seeing as much of an effect because with time, the ones that were going to tear, and that people were going to do pretty good. And that we would start to see kind of the results coming together and no difference. And the power of Mars is that when we looked at 6-year results, at that time in the English medical literature, there had only been 4 revision ACL studies published with a minimum of 5-year follow-up that involved a total of 116 patients. So that's how crazy this database is. So now we had a re-rupture rate of almost 6%, and actually the allografts were increasingly leading to failure. So now it was 3.85 times less likely to re-rupture if you had an autograft versus allograft. BTB allograft was 4 times more likely to rupture than a BTB autograft. We still couldn't show a difference in soft tissue versus BTB. And I can tell you, you do the studies and you believe the science, and now I'll use a hamstring or a BTB autograft on my patients. When I had a huge bias that BTB autograft was the best graft, studies don't show it. So I've started using hamstrings when that's not available. Knock on wood, is probably waiting in my clinic on Monday, but I haven't had a hamstring revision fail that I'm aware of. But the results at 6 years, even stronger, that autograft was better than allograft. And we don't have enough failures quite to layer it out and say that after a certain age, an allograft is safe. In Moon with primaries, you can pretty much say after 40, you can use an allograft in a primary, and the failure rate's going to be 2% or less. We can't say that yet with age, and it's probably true, but I don't have the data to tell you that past the age of 40 or 50, you can use an allograft in the revision setting and be safe. So then people said, yeah, but Rick, the patient walks in, they've had this graft done, I don't have any choice. I have to use an allograft, or I have to use an autograft, or whatever. And we said, I just don't have choice. So then we said, what really drives graft decision? Do surgeons actually have choice? We did this propensity study, and some of you out there, you ought to look at propensity because it really is a cool way to look at some of the clinical questions that we have in orthopedics, and we don't use it very much. So what we want to do is what factors predict graft choice? So they measure the probability of why you select a treatment. In a randomized trial, you get forced into whatever treatment you're doing. In a propensity study, we can look at what kind of caused you to make this decision. And so it's best when it's like a really bunch of different variables and it's a crazy data set. It actually, propensity works better. So what did we find? Well, we found that the number one, 5 times any other reason why you got the graft you got was because of who the doctor you saw. So if you saw Rick Wright, you got an autograft. If you saw other people that did mostly allograft, and that previous graft was 1/5 of the driver of who the doctor was. So the doctor can make the decision. But this also tells us that if we educate the physicians that they need to be using autografts in the revision setting, that's who we can impact. It doesn't matter what the patient thinks or wants. If we can educate the patient, the physicians, that's the number one driver of the graft that they're using. It's not how many times they failed, what they had previously, what they do, what their age. None of that was driving it as strongly as who their surgeon was. So then we wanted to look at some other things, meniscus and articular cartilage. If you don't remember anything from this talk today, remember this slide. This tells you how beat up this cohort is compared to primaries. Only 9% had normal articular cartilage and normal menisci. So articular cartilage grade 2 or worse, or a meniscus tear that either got resected or repaired in 91%. 60% had both articular cartilage damage, worse than grade 2, and a meniscus tear. That's crazy. Primaries, not even half this, not even a fourth this beat up. So this is, when you get a revision, when you tear your ACL graft, and you're going through this a second time, your knee is beat up. Looking at what predicted outcome, a previous lateral meniscectomy. So at the time of your primary or before you had your revision, if you had a lateral meniscectomy, that was a bad predictor for a bad outcome when you then subsequently had to have a revision. So previous lateral meniscectomy was a strong predictor for PROMs that you're going to have a worse outcome. Looking at articular cartilage, that old patellofemoral joint, for all us sports people, like I call patellofemoral pain the final common pathway. I don't care if 2 years ago you saw me for rotator cuff disease, you end up in my clinic with patellofemoral pain. It's the final common pathway. Well, it gets you if you have a revision too. Trochlear groove chondrosis is the strongest predictor for worse outcome based on articular cartilage damage. And that's for basically all of the KOOS, WOMAC, and IKDC. Looking at that at 6 years, 2 most consistent outcomes were previous or current medial meniscus. So by 6 years, it had shifted to medial meniscus, but still patellofemoral chondral pathology. So here you can see that previous, both medial and lateral, medial a little stronger than the lateral at 6 years. And then articular cartilage, you see those bottom 2 rows, strongly predicted worse outcomes for KOOS, WOMAC, and IKDC, either the patellar or trochlear groove. Looking at surgical predictors, so this is important. Is there anything that I can do to change the outcome that is in my control beyond graft choice? So we focused on 3 areas: surgical approach, tunnel position, fixation, biologic factors. So surgical approach, if you had a prior arthrotomy, that predicted a worse IKDC. If you had a double bundle, double femoral tunnel, that predicted a worse KOOS. If you said it was the ideal tibial position and it was not enlarged, so if you said the previous tibial tunnel was perfect, that predicted a worse outcome. So that's what I was talking about with Drew. I'm not sure that we know what we're talking about. And a notchplasty, now these are independent predictors of a worse outcome. So a notchplasty, that if you needed a notchplasty and did one, that ended up with a worse result. And everyone says, well, that's just a surrogate for chondrosis and chondral and overgrowth, but it's an independent predictor, so it's not necessarily true. Factors didn't impact outcome. I thought these snowman, big blended tunnels where the graft is just all over the place, no, didn't predict it, so I was wrong. That was my bias. And then the knee position that you use at the time of graft fixation didn't predict. So within reason, you can put the graft in full extension or a few degrees of flexion. It didn't matter. Things that did help, fixation with a metal screw. That just may be because some of these tunnels are a little dilated or whatever. Predicted a better outcome. Tibial fixation with something other than a metal screw was a worse outcome. So when you're using BTB or whatever, maybe use a metal screw. Femoral bone graft predicted a lower marks, but if you decided not to graft the tibia, so bone grafting the tibia didn't result in a worse outcome. Biologic enhancement didn't have any positive impacts. And that's kind of a little bit all over the map, but mainly it was PRP around the graft or into the knee at the time of revision. The most consistent driving poor outcomes with arthroplasty, notchplasty, and if you said the tibial tunnel was ideal, if you used a metal screw and your bone grafted the tibia, you had better outcomes. Rehab predictors, I wanted to see if anything we did. This was a little bit of soft data, but we want to look at weight bearing early versus delayed, active versus passive range of motion, early versus delayed, whether or not those expensive braces we put on in the operating room mattered, and then whether or not return to play, derotation bracing worked. So 2 rehab factors predicted outcome. If you did, some people were putting an ACL derotation brace on their patients basically immediately post-op, not to return to play. That, for whatever reason, and sometimes you just scratch your head and try and figure out why did that happen? But it predicted that you would have more reoperations. It was pretty strongly predictive. And then if you put people in a derotation brace when they went back to sports, their subjective patient-reported outcome measures were higher. It did not lessen the re-injury risk. So I think the brace treats their brain, but it works, okay? But you don't put a brace on them to go back to sports and tell them that this is going to protect your graft. We could not show that. But they liked the way they could do sports activities better if they put a brace on after their revision. Everything else, immediate versus delayed weight bearing, you can immediately weight bear, you can immediately move them. Nothing else predicted outcome except those 2. So no need to limit them. And putting them in a T-scope or a neomobilizer or just letting them fly, the bracing didn't help or prevent injury or do anything good. So you may be spending money that actually doesn't have much science behind it if you're using a bunch of braces in that early post-op period. So then we got NIH renewal grant, and we said, okay, it's time to try and bring these patients back. We're going to try and bring back a nested cohort and follow them at 10 years and get radiographs. So we had this big plan. We were going to have 6 sites, and we're going to helicopter in the coordinators, and this was going to be it. We were going to teach people how to do multi-center studies and then bring all these patients back to just only 6 sites scattered around the country, and we were going to initiate in the spring of 2020. And so I think everyone still remembers what happened in the spring of 2020. Don't plan an on-site study at the start of a pandemic. We eventually got it accomplished with 200 patients coming back. And I can tell you this, there is never, we've got an article in at JBJS under review. If it gets published, which it looks like it will once one reviewer just absolutely hammered us, so we've got a little work to do. But if it gets published, it will be the first ever minimum 10-year follow-up study of revision ACL reconstruction. So that's how kind of devoid of like long-term follow-up and really looking at this question we have been. So we got them all back. What did we find? We involved 40 surgeons, so pretty good spread of people. Mean age, they were starting to get some age on them. Of course, it wasn't right at 10 years because we had to wait a couple years before we got going. And so we looked at physical exam. Loss of extension was pretty common. We looked at Lachman soft endpoints, so concern about the graft was noted in 20%. Lachman greater than 5 millimeters and these are blinded surgeons with the knees covered up. They're blinded to which knee was the revision knee, and they were not the treating surgeons. So each site would have someone looking at the patient that had not been involved with the study. So greater than 5 millimeter, 10% for a Lachman. Pivot, grade 2, 26 patients. Grade 3 was really only in 4 patients. KT1000, which is the stability that sports people use, you want to be 5 millimeters or less. We had 23 or 11% with 5 millimeters or greater. That probably indicates a non-functioning graft. And then the surgeons, so that examining surgeon would say, based on me looking at this patient, I think the graft has failed. They said 37 patients out of the 205 had a non-functional ACL. Now, here's the interesting thing. You would think that if you have a pivot, you would have a Lockman, and the KT would be high, and the surgeon would think it would be torn. If you say, okay, what patients had all of these factors? I mean, you think, patient comes in with a loose knee, they're going to be, it's going to be easy to see, and we only had 8 patients where people agree, where all of these factors kind of said, yeah, it's failed. So we're still a little bit uncertain about how to make some of these diagnoses, but it looks like the failure rate at 10 years had climbed, and that by bringing them back on site, we were able to show a little higher failure rate. Now, here's the sick part. We got radiographs, and I started looking at them. No baseline radiograph on any of these patients showed joint space narrowing, okay? So at time 0, 10 years ago, they had grade a Kellgren-Lawrence 1 or 2. So a Kellgren-Lawrence 3 is joint space narrowing, you can see, but they've got more than 50% of the joint space left, as we defined it. There's a little softness out there, but this is how we defined it based on other studies that have done this in our previous work. A Kellgren-Lawrence 4 is 50% joint space narrowing or more, so bad. So a 3 or a 4 is you look at the x-ray and you say it's narrowed. So, headed obviously in the wrong direction. 56% had Kellgren-Lawrence 3 to 4, while only 14% in the opposite knee. So more than half of these patients had significant osteoarthritis that was showing up. But the crazy thing is that a bunch of people looked great. So a real dichotomy. 90, 95 patients, grade 0, 1, 2, they look great, they're functioning great. Half the patients look bad. So why was that? So we said we got to figure out what the predictors are. So here I'll give you a couple examples. Look at that x-ray baseline on the left. That's pristine. It looks great, okay? Look at that at 13-year follow-up. It's just trashed. That person's going to, be scheduling a total knee, probably relatively quickly, and it's a 35-year-old female. That's just devastating. Here is 15-year follow-up, similar picture. A little bit of osteophytes at baseline, but good joint space. At 15-year follow-up, terrible. It's a 36-year-old female. And you got this one. 35-year-old female, looks great at baseline, looks great at 12 years. I mean, we'd be high-fiving in the clinic with that x-ray. So why are these 3 patients why are they looking like this at 12 years? Why some look so poorly and some look good? Is it just meniscus? So we run all the regression analysis, and it's really not the meniscal and chondral damage. It's not strongly correlated at 10 years. Age and BMI did predict, so if your BMI is over 25, you're going to start to, it does predict that you're at a higher chance of ending up with arthritis, but it's really pretty soft. And so taking this, we've now reapplied to the NIH for our next grant. It got scored pretty well, so I think we're going to be able to do it. Vanderbilt is really strong. They've got a BioView bank of 300,000 plus total DNA genomic samples. So a lot of expertise there. So we're going to work with them and get saliva spit samples on as many of these patients as we can, but specifically these 200. And then we're going to try and come up with a polygenic risk score and see if there's a genetic basis of why this dichotomy of knees look pretty great at 10 years plus and knees look terrible. And what I think we'll find out is that if you have some genetic predictors and lose a meniscus, or I think we'll find out a couple, 3 things. But the beauty of this, and people said, well, when we got the reviews back on the grant, this isn't practical. If I told Ben that, hey, you're undergoing a revision ACL, and I can tell you with a $200, which we're getting close to that, a $200 genetic analysis, what your knee's going to look like at 10 years if you continue to run or go hard on it, or you need to modify your activities. I think most people that are undergoing a revision ACL would probably want to have that information. So I'm hopeful that we can find some predictors to tell these people, hey, your knee's going to hold up pretty well. You can do whatever you want, or you need to really watch what you do, or you're going to be 35 and staring at a knee replacement, which, we've gotten really good with our arthroplasty, and we know they last a long time, but I don't think anyone in the crowd would want one if they're in their 30s, or would have wanted one when they were in their 30s. So sorry, Tad, it's not a perfect operation. All right, I'll get us to lunch. So in conclusions, this is it's been really fun doing this and working with all the sites and the patients. And what have we learned? Autograft decreases graft failure. Someone asked me that this morning. We could not predict that graft choice predicted who got arthritis. So probably is not graft specific. If you had a previous lateral meniscectomy and you're doing a revision on the patient, tell them they've got a good chance of ending up with a worse outcome. Patellofemoral chondrosis predicts worse outcomes. Use a metal screw, bone graft if they need it. Don't do a notchplasty if you don't have to. You can do early range of motion, weight bear immediately, but don't need to put them in a brace. But you might want to put them in a brace when they go back to sports because it'll make their head better, but it won't affect their knee. And unfortunately, 50% at 10 years have significant osteoarthritis. Strengths, it's been prospective, validated, patient-reported outcomes, big numbers so that we can do these crazy analyses. Multi-surgeon, multi-center, generalizable because we got private practice and academic people involved with it. So it really allows you to say this applies to any sports medicine clinic. And it shows you how if you want to do great studies, you can pick a topic, and even if it's rare, relatively rare, you can get people involved. People enjoy participating in research. It was great for AOSSM and the society. So there's a lot of things you can look at. You can look at carpal tunnel releases, and if you get enough numbers, you can find out things that you just can't find out in a single institution study or a single practice study. So, it's team. We love working in teams when we're in sports. So our regular on-site follow-up was limited by the study design, but we were able to overcome that with the on-site kind of nested cohort but still, without doing those nested cohorts and sending the coordinators in, it's hard to standardize PE, physical exam, x-rays, and stability testing. Maintaining the follow-up long-term has been hard. It's an amazing number of people in this cohort that ended up in prison. I don't know what that says, but I don't know. There's just a lot of people in prison that do not want to fill out questionnaires and you can't get a hold of them. So it's hard and expensive. I always call it herding cats and elephants all at the same time. So thank you. Everybody wants to go to lunch.
First question of a great, very impressive work. This is obviously for people in the audience that doesn't know. This is like 2 decades of work, or even longer. Started with Moon and become Mars. Share with us. We all know it's difficult. What makes it work for you? What makes it work for you to kind of get the study, and how do you kind of coordinate this? Because I think the challenge for us is that we always have the fear that, we can't do it. What kind of keep this going for you, and what advice you have for some of our young faculty, people that are actually excited about doing clinical work?
Yeah, I will say that it helps. It helped that this was a question. This was a problem that a lot of people that do sports medicine, a lot of senior, ACL surgeons knew that something about that revision thing's different. So that was good. I think that it at the end of the day, it takes somebody that really wants to drive it. When you put these groups together, somebody does kind of need to taking charge and making it work. We've had continuity with our follow-up person, continuity with Laurie, and that has helped because it's such a big complex. But you do there's no doubt that if you're a young academician, you can gain more notoriety by publishing on your own patients and just being, this is Rick Wright series, but you can't do as good a science. And you don't get the benefit of the team. You and I are friends, partly because, in large part because of all the work we've done on Moon together. It's been the most gratifying research and work that I've done outside of department work in orthopedics. And it's led to friendships and relationships and the best science. But it does take a little bit of a group mentality. And, people call me all the time now when they want to start one of these groups, and I talk through the challenges. And so academically, you're putting somebody up for promotion, and they've been working really hard in some of these groups, but maybe they didn't end up as first and last author. So you have to find ways to make sure that promotions committees understand it. So there's a little bit of a challenge there, because I, after 3 or 4 articles where people were arguing with me where they should be on the masthead, I said, I'm done. And I went to corporate authorship, which probably realistically hurt me more than anyone else, because I've written the most of these articles where I would have been first author. But I just said, I just want to take the ego out of it and just go Mars on the masthead, and then we make everyone PubMedable. Some people don't want to, they struggle with that. And I have some groups that have said, well, we're not going to do that because I need to be on the masthead. And I go, well, you're going to have other people that start getting mad and start taking pot shots, and the culture falls a little bit. But no, it's gratifying. It's been great, and you do the best science with this stuff. So, I don't know if I answer your question or not, but and happy to anybody that wants to talk about it or has an idea of starting one of these groups. Rock, Jupiter, all those I've been kind of involved with at the start to try and help them get started. So it's been great. Yep.
Thank you, Dr. Wright, for a great talk and walking through the kind of history of all of Mars and how it's created and some of the new 10-year findings that will come out soon. My question was geared towards those findings. You said that meniscal and chondral pathology, I think at the time of revision, was not associated with development of arthritis. Any thoughts as to why that is? Is it the synovium, the time of injury, or I know we don't have necessarily the answers, but kind of your general thoughts about what you might be missing?
Yeah, if I understand your question correctly, so they were weakly predictive, but what you'd like to see is that if you have a meniscectomy at time 0, not like to see, but I mean from a be able to manage the patient, you'd like to say, when you lose your meniscus at time 0, at 10 years, you're going to be in that grade 3 and 4 group. It didn't work that way. We had a ton of people that lost their meniscus and had completely normal looking x-rays at 10 years. So we know that losing your meniscus is not great, but we couldn't use that as the sole predictor of why these people were ending up with such horrifically looking x-rays at 10 years. A typical meniscectomy, and we all do a ton of meniscectomies. The typical meniscectomy in a normal joint doesn't look like that at 10 years, Yeah. So we got to figure out a little bit more what's going on. Yeah. But from you saying how your knee feels, so Koos and Proms and IKDC, when you had a meniscectomy, so now this pushes it out. So a few years ago, you had a primary ACL, maybe you tore your lateral meniscus then, or in the next couple of years you tore your graft. If you'd had even more time, but that still did not predict these really bad x-rays at 10 years. So it kind of sort of pointed in the direction, but not statistically significant. And I would have thought it was going to, so we did the analysis, said, okay, we'll find out 2 or 3 things, and then we'll all start doing meniscal allografts, and we won't end up with these x-rays. But it's not, we got to find something, there's something else out there that's causing half these patients to end up really poorly at 10 years.
Makes sense. Thank you.
Thank you so much. Really, really impressive work. My question is, do you have any data, or has anyone published on the rate of grade 3 or 4 arthritis in people that have a re-rupture of their ACL graft and do not get a revision? So how helpful is this revision anyway, I guess, is my bottom line question.
So, no. I'll say a couple things. We've got the same data at 10 years in Moon. It's under 20. It's well under. It's about 14% have grade 3 or 4. So the primary this is way worse than the primary cohort, and we cannot say again the.
Well, so let's say I had my ACL fixed 12 years ago.
Yeah, you decide to go non-op.
Rupture. I'm like, you know what? I don't want to take time off work. How is that going to be changed?
This group will not undergo the next revision, the next reconstruction. It's crazy how much this group thinks I had an ACL tear, I gotta, even when I tell them, you know, the results of this are not great, you might want to think about, and the knee after tearing their graft is a lot of times looser than you see with the typical primary. There are just not many people that come in, unless they already have arthritic changes, that you can just go, this is ridiculous, you really shouldn't. This group wants the next ACL reconstruction. And I'm not saying that's why you should do it, but this is not a group you're talking into surgery. You're trying to talk them out of surgery. So we don't have a great cohort of non-operative managed ACL graft tears.
Got it. Thanks.
Drew, you got a bunch of those in your clinic? I don't.
No, I agree. And thanks for a great talk, and congratulations on all of this work. But kind of in that line, how do you practically talk to these patients about expectations and activity after their revision reconstruction? Because like you said, their impression is often, well, I had this once before, we'll just go put in a new one, all be great, but it's a much more complicated problem. And then it seems like activity may or may not change that long-term outcome. So what do you tell them is reasonable to expect, reasonable to do, and how do you frame that discussion when you actually talk to patients?
Yeah, so this has changed me dramatically, this 10-year stuff, because I kind of felt like if they were doing pretty good at 6 months or a year or whatever, and they didn't have a bunch of chondrosis or and their knee looked pretty good shape, I wasn't really telling them to slow down that much. I'm now going to say, we don't know exactly why, but you got at least a 50% chance that you're going to have a trash knee at 10 years. And if it were me, I would do non-impact cardiovascular, Stairmaster bike, swim. I can't stand swimming. So, I just lay it all out for them so that they have options. But I say, this is not a knee I would play basketball on, soccer on, or run long distance. Because we don't know. Now, I hope in 5 years I can say, hey, $200 and I can tell you if you can do whatever you want or if we really need to restrict you. So that's my goal, is that we can get a predictor. But right now I'm way more conservative in what I tell these people than I was even when I was doing Mars.
Thanks.
Hey, Dr. Wright, just wanted to say I really enjoyed your talk. My name is Gary. I'm just a medical student. My question is, how do you incorporate studies like fragility analyses into your surgical decision-making and graft selection? And also plugging our own study with Dr. Feely, we're looking at the statistical fragility of PEDS, ACL reconstruction autografts, and we're finding that, there isn't a single, best option. Is more of a individualized.
Yeah, I'd say we're a little naive and not using fragility really much for predicting, for clinical use in the ACL cohort. We're doing a ton of young teenagers. We don't think about that much, so we've got a lot to learn about that. So we need y'all to continue to do that work.
Stay tuned.
Educate us.
Yeah.
You gonna do orthopedics? You want to do orthopedics?
100%.
Yeah, good answer. That's Vanderbilt University Medical Center, Nashville, Tennessee.
Everyone for your attention. We have lunch upstairs on the 11th floor. We were going to have a lunchtime talk, but unfortunately our speaker is stuck in jury duty, so it'll be a social hour, so enjoy.